Welcome to SUNAR's third webinar. It's titled Harm Reduction and Social Justice in Carceral Settings. My name is Steve Caldwell. I use he, they pronouns, and I'm one of SUNAR's regional peer leads. Before we begin today, there's just a few housekeeping items as usual to discuss. So as we just talked about, the event is being recorded and will be shared on our website and social media within a week. If you're having technical difficulties, we suggest trying logging out and rejoining, but you can also reach out to me via the chat and I'll try to do my best if that doesn't work. Please use the chat function to introduce yourself, a land acknowledgement based on where you're joining us from today, and anything else you would like us to know. If you have any questions or comments for the presenters, please put them in the Q&A box. If your question is directed to a certain speaker in particular, please identify this in your question, and we will be saving all the questions to the end. We will be providing at the end of this an anonymous survey, a link in the chat after the presentation, and we really appreciate your feedback so we can continue to improve and grow and get the necessary data to do our best work. If you would like to learn more about SUNAR, which we hope you do, please visit our website at https://sunar.ca, or check out our Facebook page. It's SUNAR, Sun Atlantic Region, and Katie's going to put that in the chat because I just jumbled it as I said it, which would help a lot. So next we're going to do land acknowledgement. If you can pull that up, Carol, followed by our safer spaces statement. Much. Go away. One moment, please. Just having trouble bringing that up.
You need someone to read that, Steve?
Yeah, if you could read that, Gary. It's just not opening up for me.
Sure. It's a virtual SUNAR webinar land acknowledgement. SUNAR would like to acknowledge that we are all sitting on the unceded and traditional territories of Indigenous peoples. Together, Nova Scotia, PEI, New Brunswick, and Newfoundland are traditionally called the Mi'kma'ki. Our members in Nova Scotia and on PEI are situated on the territory of the Mi'kmaq. In New Brunswick, we are sitting on the land of the Wolastoqiyik, otherwise known as the Maliseet or Mi'kmaq. We respectfully acknowledge Newfoundland or Ukdahumguk in Mi'kmaq as the ancestral homelands of the Mi'kmaq and Beothuk. Others say it that way. We recognize the Inuit of Nunatavut, the Inuit of Nunakavut, the Innu of Nitassinan, and their ancestors as the original people of Labrador. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we may care for each other in our own way to try to move forward in a spirit of reconciliation and collaboration.
Thanks for that, Gary. The safer spaces one came up for me, and I got rid of my little sidekick, so I apologize for that.
All good, buddy.
So this is our safer spaces statement. So in this virtual space, we will treat each other with respect and dignity, regardless of age, race, gender expression, gender identity, sexual orientation, levels of ability, spiritual practices, and all other diverse identities. Everyone entering the space has a responsibility to uphold these values. SUNAR is committed to and encourages all those who gather with us to speak from personal experience and avoid speaking on the behalf of others. Try to use I statements to share reactions or experiences such as I feel, I'm affected by. Don't make assumptions about others' identity or experiences. Listen to each other so we understand the various perspectives. Share beliefs, opinions, and points of view rather than judgments. Maintain confidentiality. Information shared here should stay here. Be mindful of pronouns of others and use them. It's okay to ask if you don't know. And again, we are all here to grow, to connect, and to share our experience, knowledge, and light in this space. All right, so moving right along. Before I introduce our first presenter, I want to tell you briefly about SUNAR and the organization that is hosting this webinar. Direction 180 receives funds from Health Canada's Substance Use and Addiction Program, SUAP, to create SUNAR, the Substance User Network of Atlantic Regions in August of 2020. The SUNAR project seeks to adapt a peer-led model based on the needs of people with lived and living experience of substance use in 8 communities across the Atlantic provinces, sorry. So Truro, Sydney, and Halifax, Nova Scotia, St. John, Fredericton, Moncton, New Brunswick, Charlottetown, PEI, and St. John's, Newfoundland. SUNAR aims to unite, inform, and open dialogue between people who use substances in Atlantic Canada. It also strives to increase engagement between people who use substances and service providers and policymakers to decrease substance use-related stigma and isolation, and increase evidence-informed policies, programs, and practices. Ultimately, SUNAR works to enhance and save the lives of people who use or use substances. And I'll say personally, the fellowship is a huge force within it that helps create a community in all of us that we share together. SUNAR's key partners, with the help of a key partner, harm reduction organizations throughout Atlantic Canada, SUNAR engages within a network of approximately 40 people with living and lived experiences using substances to participate in knowledge exchange, skill-based workshops, and other capacity-enhancing activities. So we have a monthly newsletter that we use to both tell stories and recruit allies. Anyone can sign up to receive our monthly newsletter, which is a collection of harm reduction and substance use related resources in Canada with a specific focus on Atlantic provinces. And Katie, I believe, is already dropping a link on that. And I had the honor and humbling experience of interviewing Katie just recently. And I suggest if anyone wants to learn, be educated in an empathetic and integral way, you might check it out. So yeah, Katie's dropped that. Anyone interested in receiving it and therefore becoming an ally of SUNAR, check that out. I really appreciate it. Slide 3. Without further ado, our main event. So you've heard me ramble on. Hopefully you've been all right through that. Our first speaker today will be Holly Richards, and I'll introduce her. So Holly uses she, her pronouns and is a registered nurse from St. John, New Brunswick. A little shout out to my hometown that I miss very much, with a practice grounded in the philosophy of harm reduction. She's an avid harm reduction advocate in her community with experience working with people who use drugs in acute care, correctional rehabilitation, and the community setting. And Holly, the stage is yours.
I'm muted. Thanks, Steve.
You're all good.
All right.
Cool.
I will share my screen. Okay. Can everybody see that? There we go. All right. Well, thank you for the introduction. I'm really passionate about social justice and how we can, implement harm reduction in the carceral setting. So I'm not going to bore you with details about myself because Steve just introduced me. So I'm going to get started. I do acknowledge that New Brunswick is situated on the beautiful, unceded, and unsurrendered territory of the Mi'kmaq, Wolastoqey, and Passamaquoddy peoples. I really like this quote and I wanted to share it. So often incarcerated people are treated differently than a patient in a hospital or a community clinic would be treated because they committed a crime. So this lends to the opportunity for social justice or social injustice, when it comes to their healthcare while they're incarcerated. So the quote is, "Justice denied anywhere diminishes justice everywhere." So my objectives for my portion of this presentation are to define social justice, define the common concepts associated with social justice, discuss some injustices faced by the incarcerated people who do use substances, and explore possible solutions to these inequities. Excuse me. So social justice is simply equitable access and fair distribution of conditions required for good health. So I absolutely love this visual, and I do share it every chance I get. It really breaks down the specific concepts associated with social justice. So inequity means having unequal access to opportunities. So as you can see in the first picture, The fellow on your left is more likely than the fellow on your right to catch the apples simply because of the way the tree is tilting. So I do think it's important to remember that in the real world, social symptoms are not naturally occurring as this tree appears to be. And they were intentionally designed to reward and benefit certain demographics, and their design can be rooted in discriminatory beliefs. So equality is having evenly distributed tools and or resources regardless of who you are. So if you look at the second square in the picture, both of my fellas have the exact same ladder to collect their apples. However, because the tree is slanted, the fellow on the left is still more likely to get more apples. And the fellow on the right, the apples are still completely out of reach. So looking at equity, so that's your third square in the picture. It involves using customized tools to identify and address the inequality. So given the fella on the right a taller ladder, so he can too reach the apples, ensures the equitable access and fair distribution of the apples. Now justice, that's the fourth picture, involves fixing the broken system. It's going to lead to long-term sustainable equitable access. So as you can see, the 2x4s that are braced against the tree ensure that both fellas have equal access to the apple. So this ultimately is the dream. So I think it's really important to understand these concepts and how they relate to social justice, because this better equips us to discuss the common injustices faced by incarcerated people who do use substances. And we all know whether our clients are incarcerated or not, the system could certainly use some 2x4s because it's less than perfect. So let's apply these concepts to real life and make it make sense for our clients that we serve in the incarcerated setting. So the example I'm choosing to use is the opportunity to attend school. So given that there are no behavioral obstacles, it's an opportunity available to all incarcerated people for the most part, from my experience. So let's say we have one person who has no history of ADHD, no history of mental illness, no substance use disorder, and he's being held on a minor charge, and he takes advantage of this opportunity. And then we have another person who is undiagnosed with ADHD, meaning he's not medicated or receiving any intervention, and he also takes advantage of the opportunity to go to school. So who do you think is going to have the better outcome? So this is equality. So they're given the same opportunity, but their individual circumstances are not taken into consideration. So equity would ensure that the person with undiagnosed ADHD would have the opportunity to perhaps see a psychiatrist, receive a formal diagnosis, start a treatment regimen, which may include medication or counseling. Social justice would mean that these services are already readily available for incarcerated people, and unfortunately, they're not. So the route to achieving equity will not be accomplished through treating everyone equally. It will be achieved by treating everyone justly according to their circumstances. So I think that's a really powerful quote. So have you guys ever heard of the ACEs score? So an individual's ACEs score has quite an impact on their development. So ACEs looks at each of these domains. So physical abuse, physical neglect, sexual abuse, emotional abuse, witnessing violence against a parent, parental divorce or separation, a household member with substance use disorder, a household member with depression or mental illness, a household member in jail or prison, and emotional neglect. So each one the youth checks off counts as 1 point. So the more ACEs a child has, the more likely it will have a lasting impact on their adolescence and into adulthood. So child and adolescent health and developmental difficulties are important determinants for criminal justice system involvement. So according to a study written by Hughes al. Published in 2020, the health determinants of adolescent criminalization are neurodevelopmental disabilities, traumatic brain injury, mental health difficulties, and childhood trauma or adversity. These all increase the risk for criminal justice system contact and are amplified by social marginalization, structural disadvantage, and inequality. So I'll talk just briefly about each one. So neurodevelopment disabilities could include fetal alcohol syndrome disorder that presents with hyperactivity, deficits in executive functioning skills. ADHD, known as the invisible disability, it can be characterized by impulsiveness, hyperactivity. Autism was also listed in the study, however, the evidence is more weak. So childhood traumatic brain injury can result in functional difficulties and can affect behavior. So deficits in cognition, social communication, impulse control, empathy, and response to emotions can occur. A systematic review showed 32 to 50% of young people in custody reported a history of traumatic brain injury resulting in a loss of consciousness, in comparison with 5 to 24% of young people in the general population. So there appears to be a correlation here. And let's be real, mental health and addictions are overrepresented in the criminal justice system. So there's a high prevalence of mental illness among adolescents in the criminal justice system, with 60 to 70% of young males and 60 to 80% of young females reporting serious psychiatric disorder versus just 12% of the general population. And there is growing evidence on the potential negative implications of childhood adversity on long-term neurological development. So prolonged toxic stress does disrupt brain development and reduces the ability to regulate impulses, intensifies psychological responses to stress, and increases the likelihood for engagement in maladaptive behaviors, such as aggression and delinquency. So another point I wanted to just stress is that 1/2 of people incarcerated in Canada experience some form of abuse in their childhood, whether that be physical, sexual, emotional, or neglect. So it would be amiss not to mention the overrepresentation of Indigenous peoples in Canadian jails and prisons. Indigenous people have been overrepresented in the criminal justice system for decades. They represent 17 to 19% of all adult admissions to Canadian federal penitentiaries. This is notable to mention because Indigenous people make up 3% of the entire Canadian population. So the injustice incarcerated people often face that I want to discuss today include low or sometimes no access to harm reduction services. This is important because statistically speaking, there are approximately 10 million people incarcerated worldwide at any given time. 27% of these people are being held in pretrial or remand centers, meaning they have not yet been convicted of a crime. And 1 in 5 of the 10 million incarcerated people are there for drug-related offenses, with the vast majority being held for personal possession or use. So 90% of people who inject drugs will be incarcerated at some point in their lives. So essentially, substance use disorder is often criminalized, further tipping the scales of social justice away from people who use drugs and further marginalizing this population. Not to mention the health risks associated with IV drug use in the correctional setting when harm reduction services are not readily available. So what is harm reduction? So according to the Canadian Nurses Association, harm reduction is a public health response aimed at reducing the negative consequences of actions that increase the risk of adverse health outcomes, including substance use. So basically, harm reduction is meeting people where they're at. So why should we take this approach within corrections? Globally, prisons have high rates of injection drug use, and there is a lack of services, and it leads to an increasing risk for HIV and Hep C outbreaks. And harm reduction works. It reduces HIV and Hep C rates. It improves uptake of other health and social services. It prevents fatal overdoses, and it reduces drug-related crime. So needle exchange programs are readily available within the community for people who use substances. However, they are one of the most restricted harm reduction services in correctional settings across the globe. So this is due to the fear that unsterile needles will be used as weapons against other incarcerated persons, correctional officers, and other staff. In over 25 years of needle exchange policies in the prison setting worldwide, there has not been a single reported incident of assault with a needle, according to the HIV/AIDS Legal Network. The Correctional Services of Canada reported that federal prison needle exchange programs contribute to workplace safety and are not associated with increased assaults on prison staff or inmates. So this perceived threat has been disproven in the literature time and time again. The social injustice exists because access to needle exchange programs varies considerably from the community to corrections. So for example, in New Brunswick, there's no access to sterile injecting equipment within the correctional setting. There is a significant amount of evidence published that affirms this contributes to Hep C and HIV numbers within the correctional setting. I was featured on a blog. It was formerly known as the UPHNS blog, and it's now called the Drug Hub. So my blog post was arguing for access to needle exchange programs within the correctional setting, and this blog can be found here if you're interested. And I think Katie has the link and can put that in the chat. If not, I can put it in the chat later. So opiate agonist therapy is more available for incarcerated people when in comparison to the needle exchange program. However, access is still not equivalent to what is available in the community. So currently, at least one prison in 54 countries has opiate agonist therapy available to clients. So when you compare that to the 86 countries that have opiate agonist therapy available for people in the community, the inequity is obvious. So on a positive note, there has been a 4% increase in access when compared to 2014. So access has definitely improved in New Brunswick over the last several years, which is exciting. So just because something is available, it certainly doesn't come without its flaws and obstacles. I once heard a story at a conference from a speaker. He was a client in a correctional center in Nova Scotia. And in order to receive his prescribed methadone, he was made to strip down to avoid medication diversion. So how inhumane is this practice? This person was left with trauma of this experience, and ultimately you shouldn't have to face trauma to receive your prescribed medication, period. So I think it's important to recognize that when people who use drugs become incarcerated, their access to their drug of choice is no longer available to them. They endure a wicked withdrawal and often do not have immediate access to opiate agonist therapy to curb those peak withdrawal symptoms. So just keeping that in mind is important. Another harm reduction strategy is overdose prevention. So incarcerated persons are more vulnerable to overdose than the general population, both during and after incarceration. The forced periods of abstinence, the changes in drug purity, change in method of use, change in drug use behavior all contribute to this. So the risk for overdose death increases 3 to 8-fold during the first 2 weeks one is released from custody in comparison to the non-incarcerated person with polysubstance use disorder, according to a study. So take-home naloxone, which was pioneered in British Columbia, is available in some federal and provincial correctional settings. Naloxone available for correctional offers in Canadian federal prisons and some provincial jails, but it's not yet available for incarcerated peoples. So before I moved out of my role at the correctional center, I had this Narcan within the units project set up to launch, where incarcerated people would have access to naloxone while they were incarcerated and be empowered and educated on how to reverse their own or their friend's overdose should it occur. So this project, unfortunately, has been stuck in red tape, and to my knowledge, it hasn't yet been implemented. Ooh. Great. So what can we do about this? So the big theme that I see when I consider the lack of harm reduction access in jails and prisons is that the services available inside do not equate to the services available in the community. So advocating for equitable access to harm reduction services such as needle exchange programs, opiate agonist therapy, and overdose prevention initiatives is advocating for social justice. Advocating for equitable access is important, and educating those around you that might not recognize harm reduction as an effective method to manage substance use disorder while incarcerated. Trust me, it's easy to become defensive, put up a wall, and fight the big social justice fight, but ultimately, this really doesn't get you anywhere. If I learned anything from working in a jail, I learned if you are persistent enough, you can have a positive influence on people through advocacy, education, and compassion. I'll wrap up by stating that there is a place for harm reduction within corrections. I advocated for and practiced harm reduction while I was the lead nurse at the St. John Regional Correctional Center daily for 3 years. Despite these efforts, inequities do still exist between community and corrections, but I encourage anyone who works with patients who may have had or will have contact with the correctional system to be cognizant of these inequities. So I'd like to thank you so much for your time, and that is all for me. I'm going to show my references here, and then I will stop sharing. Thank you.
You're muted, Steve.
That was a lot of nothing then. Thanks for that, Pete. Thanks for also your presentation, Holly. All your lived experience within that world, and for helping out where you can. There's a ton of knowledge packed into a short amount of time, and I really appreciate it. Moving on to our next speaker, we have the enigmatic and amazing Pete Brown. Pete Brown uses he, him pronouns and is currently the National Program Manager for the Seventh Step Society of Canada. Pete has lived experience in addictions and prisons and brings a unique perspective with education. And I will add into this a ton of empathy and heart. He's a social service worker, and different employment and volunteering positions in the fields of addictions and with people who have had conflict with the law. Pete has dedicated his life to helping others to get out and stay out of the criminal justice system, and is a firm believer that lived experience has a massive part to play in the change process. And feel free to take the floor whenever you're ready there, Pete.
I can't turn my video on. It's not letting me again.
Oh, if the host could allow Pete.
Oh, there it is.
We're good.
All right. Hi, everyone. Thanks for the introduction, Steve. Great job. And Holly, great presentation. Like Steve said, there was a lot of knowledge packed into that. And so much of it resonates in my own life. So I appreciate that. I'm going to start off with a little bit about myself. So as Steve had mentioned, I have lived experience with incarceration and with substance abuse disorder. I have multiple decades, we'll say, of involvement with both, pretty much since the time I was born. I was involved with it somehow, either through family and my father, and then through myself once I started to get a little older. I've been in multiple prisons in Atlantic provinces, in Newfoundland and New Brunswick, in between. Never had the joy of Prince Edward Island, but I got all the other provinces in Atlantic covered. So, and dealing with substance abuse disorder, with substance use disorder here in the prison system was an absolutely horrid experience. There's very little while I was incarcerated. I know things are moving forward now, working in the field for the last 8 years and being in recovery myself. For the last 8 years, that's when I decided that I was going to start helping others and change and help people change so they could stay out of prison themselves. Working in the addictions field, I worked at Direction 180 for 5+ years as a case manager and a intake coordinator. I worked on the mobile unit. So frontline was I loved it, to be completely honest. I loved the frontline work. And when I made the change to become the national program coordinator for 7 Step Society, it took a long, deep thought decision to make that move. And but I decided, I still work frontline in my spare time outside of my professional job. And I thought, it's a nice way to be able to keep that involved in my life. And sometimes I find that I don't have enough time for it all. I don't know if anybody else feels that way, but I'm constantly that way. And people are always telling me I work too much, and it may be my new addiction. But you know what? I love what I do, and I always tell people, if you love what you do, that you're never really working. Talking about incarceration, and there was a lot of stuff in there, Holly, that that I really touched base with me, because of lived experience with it. And some of the stuff was like, the no cookie cutter is massive, and I think that doesn't get talked about as much as it should. That we can get into statistics and talk about, well, this works for 60%, this works for 70%, this works for 80%. The problem with all that is that the other 20, 30, 40% get left outside of that. And I think that moving forward, that we really have to keep that in mind, that there is no cookie cutter. It's an individual journey through life. So we really had to keep that in mind and accept people for who they are and what they are and where they are. The prisons themselves are breeding grounds of bad habits. That's what I like to call them, universities of bad habits. So, we talk about the trauma and stuff that, people have growing up, and whether it's mental health issues, growing up in addictive addictions in their homes or their social standing. And, people end up in prisons for a multitude of reasons. But the realism of this is that those 3 big topics, and of course racial as well, right? So those 4 big topics are massive in the prisons. Spending over 12 years incarcerated myself, I never met too many millionaires in there. I don't know why that is, but I really didn't. There was a couple, but not many. Most of the people came from poor neighborhoods, a lot of Indigenous, a lot of Black, a lot of mental health. It was massive in there. And these things need to be, the same as addictions, needs to be looked at as a health issue, not a behavioral issue. So we have to get into more of that understanding of that. And, the system itself has to create these opportunities for people to be able to deal with these issues as we move forward. So what happens is we take people that have these multiple issues in their life, multiple barriers, and then we put them into a place where everybody else in there has multiple barriers, and it kind of feeds off each other. Which is, for myself personally, when I went inside, I didn't use hard drugs. I didn't use IV. I didn't, even through my first sentence, when I got back in there, my second sentence, what happened was all these things became more normal because the people I was surrounded with were doing them on a daily basis. So it was very easy for me to pick up, different substances. It was very easy for me to pick up different ways of using substances. And of course, it became very problematic the further I went down the rabbit hole, because what happens is that these types of behaviors, these types of beliefs become normal. And of course, what that does is seclude us more and more from society, because we get wrapped up in this very subculture, small subculture, but we think it's the world. The needle exchange program, which Holly touched on, I did a talk about that a while back on the radio, and the union for corrections is, you know, their big pushback is that it can be used as weapons. They said the same thing about bleach back in the 90s when they introduced bleach to the prisons to be able to clean syringes. You know, they were like, oh, they'll be throwing it at us, they'll be using it as chemicals against us and all this stuff. And you know, like I said, I spent over 12 years inside and I never seen bleach used as a weapon once. And it was always accessible. Also, what they're forgetting to mention is that the prison already has syringes in them. They're everywhere. Mind you that they are used over and over and over and over and over again. You know, I've seen them to the point where people were making their own syringes out of a eyedropper, a gold hoop earring, and sharpening it up on a little tiny piece of sandpaper to use as, you know. So when we talk about the health issues that come with these types of things, you know, like the spread of disease, HIV, hepatitis, you know, and then of course you start talking about the cleanliness of it, which creates a whole nother wall of health issues. This is what the needle exchange, of course, would help, you know, get rid of in our systems. The problem with it is that it's policed to the point where it's used as, you know, it's very stigmatizing the way that it's set up. So what happens is the person goes and gets, you know, gets involved with the needle exchange program. They know who it is. They're watched constantly. They know who's going in their cells. Everything's on camera. So they, you know, what happens is that if a person is trying to get to lower security, trying to get an early release, trying to get all these types of things, it's all used against them. They may not say it on paper, but I can guarantee you that that it's being used right behind the doors. So these types of situations are, you know, they're very, very difficult and delicate because, I mean, obviously a person, if they're incarcerated, they're going to be watched. You know, that's the whole point of being in there. So where's that balance? Where is it going to work 100%? We're not going to know until we try different things. Even with the needle exchange, there's so very few people that are using it that the syringes are still being shared quite a bit because people will not get their name put on the list because of the reasons that I've already mentioned. You know, they want to get sent to lower security prisons. They want to get early releases. When we talk about a person being released, for myself personally, you know, after going through the different stages of it multiple times, and then working in the field and watching people go through the different stages multiple hundreds and hundreds of times, there's a couple of big things that I've learned. And one of those is our most vulnerable places for reintegration. So the very first one is the release itself. You know, when a person first walks out, they're so overwhelmed with everything going on, whether that is, I lost track of time here, but hit my button. So just let me know if I'm getting a little bit far. But the three major spots are the very first, when they're very first released, so overwhelmed, trying to learn how to live in society again with being bombarded with everything from relationships, technology, employment, housing, like, you know, and then trying to deal with substance use disorder, mental health disorder, you know, all these types of things on top. But, you know, it's all piled and bang at once. So the person needs really wraparound services and a lot of support. The second section of that is when they get out of a halfway house. So they have that structure, they have that safe place almost, you know, even though there's a lot that goes on in the halfway houses, to the people that are doing well, it is a safe place because they get to step back from society a little bit and say, okay, I'm in my safe zone. So when they leave the halfway house, that's also a very massive part for a big trigger for people, right? So then we had the expiration of a sentence. So that's when Big Brother is gone. There's nobody over your shoulder anymore. And these contemplation stages is where, well, maybe I can do this, or maybe I can do that, or I can play a little bit. And this is why the numbers go up dramatically when we're talking about overdoses. When a person goes through the incarceral system, these are the big sections of it, right? Because of a multitude of reasons. And when you have a multitude of reasons, you need a multitude of supports. So being involved with these, working in the field and volunteering in the field and doing all the stuff that I do, this is what I look at when I'm dealing with people coming through the system. And it's hard when a person is getting passed around and it's not a holistic approach to the multiple issues that a person faces with substance use disorder and formerly incarcerated. I see by the time here, I'm getting lots of, I'm getting on there in time, and I don't want to take up too much. I know that we have another couple of speakers there. But if anybody, I'm always available to chat. If anybody needs to chat about any of this stuff, I'm very much involved, not just in Atlantic provinces, but right across the country. Like my title says, I'm National Program Coordinator or Manager. So I do a lot of stuff with Ottawa. Sit on different boards up there to do with, CSC and public safety and these types of things. So if anybody has any questions, suggestions, please reach out. And with that, I will pass the time.
Thanks so much. And you made me realize I was on mute last time, and I remember this time. Pete, it's awesome how much of yourself you offer from your lived experience, and to see, the contrasts and the correlations between Holly's information and yours. Holly's also mentioning in the chat some things to you. It's really gives great insight and integrity to the experience of others. And so thank you for your hard-earned knowledge and sharing with us today. And I'll pop up my notes here. So Gary is our next speaker. Gary Peddle, amazing person. I can't say too much more about Gary because I'll get emotional. Gary's helped me out a lot. Gary is a person with lived experience of substance use and in the criminal justice system, living in St. John's, Newfoundland. He's a member of SUNAR and a rock to a lot of us, and along with other local SUNAR members, uses this experience to advocate for change and give presentations in the community related to harm reduction. And wherever Gary goes, a big heart follows. So Gary, please take the floor.
Thank you, Steve. And thank you, Holly, and thank you, Pete. Can everybody hear me? I'm going to take that as a yes.
I'm great. You're good.
Okay. So I don't have all the slides and all the stuff that other people have. And you know what? I'm going to say a lot of stuff that Pete said. I went through the same stuff. I've been in all the jails across the Atlantic province except for PEI. Same thing. And I got to say, in the provincial setting, it's just not working. It's just, you're going in there and it's almost being glorified to get a whole shitload of charges and sit there in jail. And people are going in there and seeing this, and they're doing the same thing, and it just becomes a cycle over and over. Now, I'm not picking up for myself or anything. I did say that I wanted to go federal, and that did help me after the fact. It wasn't right away. It wasn't as soon as I got out, because I went to a halfway house and I got sent back to jail because I did drugs and I wasn't supposed to. And I'm not going to blame it on anybody else that was in the halfway house, but it sure didn't help to have all those people in the halfway house doing what they were doing. So, also in the jail setting, well, when I was in jail anyway, I've been out since 2019 and clean since 2019. But when I was in this provincial setting, I was seeing a lot of people coming in and getting Suboxone off people. So all these people are on Suboxone and they're not taking it. They're only taking little bits of it and they're sharing it with everybody else. And now you have a bunch of people in jail doing Suboxone and getting out with withdrawal and now have to go find stuff on the street. So this is happening everywhere, all over. And it definitely needs to stop. Everybody's getting into the same shit, going to the same stuff. Sorry for the language. So I have since become big into the harm reduction thing because I just feel that what I have been through and what I have seen with my own eyes can definitely help people. I know that what I've seen in jail, and if I can get people, I'll say it again. I've said it many times before and I'll say it again. The people that are out there doing drugs and buying it off the streets and then going to jail and then getting out and doing it again and doing the same thing over and over again, there needs to be something. I want to be able to tell those people that they don't have to go steal to get their drugs, because there's a place downtown or there's a place over here that you can go to and get clean drugs, and there's clean supplies, and you know, that's just not here. I know it's in Vancouver, but it needs to be everywhere. Why one place in Canada and not everywhere? You know, it's just not fair. And also, what else is there? So, like Pete said, the people that are in jail need, when they get out, they need to have something like the justice system, which when I was in jail, you had to qualify for it, or you had to have certain things to be able to get in this justice program, which I don't think was very fair. I think that everyone should have an opportunity to go through this program. And in the provincial jails, they don't have any programs. Like, I had to go federal to get any programming. I had to go to Stevensville, and then I had to go to New Brunswick and then Nova Scotia to get stuff. That's insane. Like, and now I know they're building a jail here in St. John's, and it's supposed to be changed, and I hope it really does change for the better. I really do. I hope that they have the right people in there, the right, you know, even like a hospital joined on to the. And another thing that I have to bring up is the dentist thing. When I was in jail, they would bring you to the dentist, and going to the dentist in jail is not a very good experience, people. Let me tell you. You were shackled and you were handcuffed into a dentist's office with other people there, and then the guards are in the room with you as you're getting your teeth pulled. And these dentists are not nice. I'm telling you, they're not nice. And yeah, so that actually put a fear of dentists into me. Now that I'm out, I'm frightened to death to go to the dentist now because of the situations that I dealt with in jail with dentists. So maybe if in jails there was dental offices and hospitals, you know, and harm reduction in jail. And yeah, so that's it. That's all I have to say. And thank you for having me. And yes.
Thanks very much, Gary. I love how you just say everything with like passion, truth, and real sees real. Thanks for everything you do, dude. Gary makes me emotional at all times in the best of ways. I'm not going to hide it. So moving on, deflecting from my emotions again. I'm just joking. We do lots of healthy emotional work in SUNAR and lots of great things. So thank you, Gary, sincerely for everything you do. Jill Harnham coming up from the Rock as well, from Newfoundland, resides in St. John's, Newfoundland, with her husband and son. Another person I had the honor to interview, another plug for our newsletter, which has more than interviews, lots of evidence-based information, education and things going along in communities about harm reduction. But Jill, more importantly, is involved in many peer roles, such as the mental health ministry. She's the director for the Worship Center, Newfoundland's regional manager for prison fellowship in Canada, and a member of SUNAR, and a peer researcher for the Canadian Center on Substance Use and Addiction. Jill's busy. Jill's busy helping a lot of people and also brings a massive heart to every situation they encounter. So Jill, please feel free to share your knowledge.
Thank you, Steve. And thank you everyone for inviting me, SUNAR especially, for giving me this opportunity. I've spoken a lot about my lived experience, but not as it pertains to the carceral setting. So bear with me. I made notes because I could go off on so many tangents if you let me. So again, thank you for that lovely introduction. I really enjoyed hearing the presenters so far. So when I was asked to participate today, I had to reflect on what harm reduction meant for me in my context, because that's a lie. I was using intravenously when I was arrested. And in my experience, there was no access to use these substances. Luckily, I had already been on opioid agonist therapy, and this luckily continued while I was in prison. There were many instances where medications were stripped from people, and I was told by the prison psychologist upon my initial sentence that if I was on my best behavior, I could keep my antidepressant. So it was like this threat of be good and we'll care for your mental health. So it was just awful. So no thoughts really came to mind about traditional harm reduction measures. As I said, I was already on the opioid agonist therapy, but I started thinking of the many ways emotional harm reduction was not practiced between prison staff and prisoners. And that includes everything from the sheriffs to the Crown, prosecutors, like just the whole justice system where there's this huge power imbalance. When I think of emotional harm reduction, I think of trauma-informed care. I believe the principles of harm reduction and trauma-informed care correlate well with one another, and I'll seek to explain my thoughts on this over the next 15 minutes or so. And now I'm going to actually share my slideshow, all that work, and I almost forgot to share it. That would have been such a sin. Okay, so I have a land acknowledgement here. I do still want to acknowledge that I'm on the ancestral lands of the Beothuk, whose culture is now permanently erased because of colonialism and us white people. We also acknowledge the land of Uktahumguk, Newfoundland, as the unceded traditional territory of the Beothuk and the Mi'kmaq. And we acknowledge Labrador as the traditional and ancestral homelands of the Innu of Nitassinan, the Inuit of Nunatsiavut, and the Innu of Nunatukeavut. We recognize all First Peoples who were here before us, those who live with us now, and the 7 generations to come. As First Peoples have done since time immemorial, we strive to be responsible stewards of the land and to respect the cultures, ceremonies, and traditions of all who call it home. As we open our hearts and minds to the past, we commit ourselves to working in a spirit of truth and reconciliation to make a better future for all. I think that's so important that we do that. So an overview of what I plan to present today, I am going to share very briefly my personal lived experience and then kind of give snippets throughout the presentation of my own lived experience in the carceral setting. Then I'm going to review the 9 harm reduction principles, highlighting the areas where I feel really speak to this idea of emotional harm reduction. And then I'll introduce a very basic understanding of trauma-informed care and practical ways we can implement this in the carceral setting, but also, I believe, in whatever setting. So in closing, then I'm going to ask that we reflect on how this can be made possible in our correctional system. So I struggled with substance use from a young age, though I never suffered many negative consequences until after high school. Throughout my 20s, I had been in 4 rehabs, too many to count detoxes, short stays in psychiatric units for suicidal ideation, and eventually at the age of 29, I was arrested for crimes I committed during a period of drug-induced psychosis in which I was reenacting past trauma while also trying to feed my need for substances to survive the pain of the current situation I was facing. I don't say that to excuse my behavior. I did plead guilty and did my time, but I just do it to give context to what I was facing at that time. The biggest wake up call for me while in prison was recognizing that I had grown up so privileged that I thought I was going to be different in the prison setting from my fellow prisoners. I was so shocked to see how similar we all were. A lot of us being mothers, experiencing the immense grief and loss of being separated from our children. And many of us having endured traumatic experiences and doing our best to cope with the terrible symptoms arising from trauma. Sadly, those symptoms were exacerbated by the harsh environment that was not conducive to healing. Sorry. I just remember thinking this could have been a great opportunity removed from society, where if the right practices were put in place and the right supports and programs. And I remember feeling from the majority of women around me that we wanted to get well. We wanted access to supports, but it was often not provided. There are 9 principles of harm reduction. The first 3 principles recognize the humanity of people who use drugs, that we are all unique in the ways we use and the reasons we use. We still have the same rights as every other Canadian citizen, and as a social justice movement that harm reduction is, it's so important to defeat stigma, that the stigma that plagues us and creates so many roadblocks to receiving the care and support that is available, easily available for those who don't use substances. Sorry, my slide is on like a timer and it's moving faster than I am. Sorry. Okay. So there is a robust body of evidence, as we've saw lots from Holly's presentation, suggesting harm reduction practices have positive impacts on the individual and the community at large. One of the ways I experienced poor emotional harm reduction had a direct impact on me and my family. Had a more trauma-informed and compassionate approach been used, the impact of my incarceration may not have hurt my family as much. Going through the judicial system to be convicted of the crimes that I pled guilty to, my family was subjected to harsh and stigmatizing language used from the Crown prosecutors and the judge presiding over the case. This was so unnecessary. I was mortified for my parents having to relive other traumatic moments, as the Crown and judge brought up an old boyfriend who caused us all a lot of serious harm 10 years prior to why I was in that courtroom in the first place. It had nothing to do with my crimes at that time. It was as if they were trying to get my dad to react while he was on the stand testifying to take responsibility for me while on bail. Thankfully, he never cracked. He's just not that kind of guy. It didn't work. But I still remember to this day the pain in my father's eyes as he heard these strange professionals speaking about me and our family circumstances, just in such a rude and like stigmatizing manner. My mother, as a result, never returned to any of my other court proceedings because this was just so traumatic for her. So we need to meet people where they're at without the use of stigmatizing language, which perpetuates stereotypes and creates barriers to getting help. We need more diverse and accessible options for treatment, such as safe consumption sites, which we don't have any in Newfoundland, and a prescribed safer supply for those who require it to be able to leave a lifestyle of drug-related crime. So let's face it, people who use drugs were the experts. This is the central principle of harm reduction. When not involved in the planning of programs and policies, it can be disastrous. An example of this was when pharmaceutical companies changed the formula for OxyContin to this gel-like substance. It forced people who use drugs to meet their needs by using substances like heroin, which was laced with fentanyl, which has led us into a disaster that we're facing today. And so many lives lost as a result. And that's because when they made this change in the formula of OxyContin, they did not consult anyone with lived or living experience. So harm reduction is rooted in a commitment to social justice, hence why we're all here today. It's all part of it. The principle addresses the inequalities that exclude people who use substances from the supports they need. Harm reduction seeks to dismantle oppressive systems. It recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities which affects both people's vulnerabilities to and capacity for coping with drug-related harms. And our final harm reduction principle simply points to the fact that harm reduction is now a public health intervention. And this means our prison staff and officials ought to be adequately equipped to carry out these principles in carceral settings while maintaining safety for prisoners and the community at large. I'm told that the training to become a corrections officer in Newfoundland is only 6 weeks. In countries like Norway, prison officers must complete a 2-year social work program before working as a prison officer. Their model for rehabilitation and punishment is completely different than ours. And I feel their success comes from investing in professionals and expecting proper education before sending them in a hostile environment with an especially vulnerable population. And from the articles I've read, it's a completely different setup where prison officers are doing they act as mentors to people who are incarcerated, not like I'm the boss of you. Like there's a real shift in that relationship. And they've had huge success and a much lower recidivism rate as a result. So my experience was that there was a big divide between emotional harm reduction provided by outside professionals coming in and offering programs and support compared to the way prison staff interacted with us. It was very easy to get locked in your cell for 3 days for forgetting an orange in your cell. In one instance, my fellow inmate was having an emotional reaction to something going on at home. Instead of offering a safe place for her to feel those emotions and to practice verbal de-escalation, she was punished and locked in her cell for the night. This young woman suicided that night in her cell. I guess my background as a mental health nurse and knowing and having the knowledge and understanding of how putting a few simple practices in place to treat people like human beings and talk through these hard, like just to see the approach that was taken in prison compared to how I was trained to treat people with dignity and respect. It was black and white. So it still baffles me to this day how this happened. It was such a tragedy. She wasn't violent. She was upset and needed someone to talk to. I just don't understand why she wasn't shown more compassion when she needed it. This is only one of 2 deaths that occurred while I was incarcerated for 7 months. The first young woman passed away as a direct result of poor prison management and a lack of access to proper psychiatric care. Even after experiencing this as a community, our attempts at grieving by placing heart-shaped sticky notes on our friend's cell door with little notes of condolences was immediately shot down as one of the lieutenants came down the range and said, take those down. And I mean, what harm were we causing there? We just weren't allowed to grieve. The next day, another officer told us, okay, today's a new day. Let's move on, as if like, someone died here yesterday, but we're not going to talk about it. Our volunteer prison psychologist came in to offer debriefing sessions after each woman passed away, but we were not really given permission to grieve outside of this space. I felt so helpless seeing the women struggle with this heaviness in the weeks to come. Sorry, paper's sticking together. Okay, so I'm just going to go an overview of some trauma-informed care practices, and then I'll go into tie that into the prison context in my experience and how I think that fits. So to be effective, the principles of trauma-informed care have to include safety, trust, collaboration, and empowerment. They have to occur at both the individual and systemic levels for effective and sustainable change. Safety, emotional safety can be promoted through compassionate care, respectful language, provider relationships that are consistent and predictable, and where confidentiality is stressed and upheld. And then physical safety can be promoted by safe spaces, having adequate space and bright lighting, and displaying art and signage that's welcoming to people and makes it feel less institutional. That was one of the positives during my experience. One of the women was invited to paint a mural on a part of the wall, and that was a lot nicer to look at than bare concrete. So when a person's basic needs for safety, respect, and acceptance in the prisoner-officer relationship are understood and responded to accordingly, an atmosphere of trust can be established. Trust is also based on predictability and transparency, such as taking the time to explain concepts such as confidentiality and allowing time for questions. Often during my sentence, I felt unheard by prison staff, and their decisions came as a surprise every time because of their lack of transparency. I'm going to skip through some of my notes here now because we are getting close, but trauma-informed program is based on shared power between a worker and client, so the relationship offers a true alliance in healing. This requires recognizing the power imbalance and the presence of privilege in the prisoner-officer relationship. And just a little on empowerment, how important that is. I've heard that come up in someone's presentation already today. Empowerment means adopting a strengths-based approach that reframes symptoms as adaptations and highlights achievements. Resilience instead of pathology is emphasized. For example, reframing trauma responses as normal reactions to threatening encounters instead of being punished for these reactions. So language plays a key role in empowerment, as individual is viewed as a person, not simply a behavior. And us at SUNAR, we do a lot to educate around language and stigma, because we feel that's something everyone has the ability to change within themselves. And trauma-informed practice means integrating an understanding of past and current experiences of violence and trauma into all aspects of service delivery. The goal of trauma-informed systems is to avoid re-traumatizing individuals and support safety, choice, and control in order to promote healing. It is not trauma treatment. There is a study that I looked at specific to trauma-informed prisons that was done in like 2012, 2014. It's in my references, so I don't have time to go through it all, but basically it's acknowledging the fact that many people are coming into the prison who've already experienced trauma, and that prison is like re-traumatizing and offers a lot of triggers. So treatment has to be diverse. So that's also one of our harm reduction principles. We got to have options because everyone is different and needs different supports. And all of these factors need to be taken into consideration that are in that little diagram there. Safety, trustworthy, we talked about that in the last slide. All of these things have to play a role. So some ways we can practically apply this in a prison setting through staff training, being mandated to attend trauma-informed training, for prisoners to have access to education regarding common forms of trauma and its effects, such as the ACEs study, learning about adverse childhood experiences and understanding that they're reacting based on things they had no control over as a child, and the likelihood of where we end up has a lot to do with that. So it takes away a lot of shame and guilt over our current circumstances. I found that anyways. understanding, why my brain ticked the way it did. Another study by a Dr. Fiona, funded by the Correctional Service of Canada in 2022, talks about the 4 R's: realization of trauma's effects, recognition of signs of trauma, response to trauma, and resistance to re-traumatization, and the 6 values that are in the diagram there. It's a systems level approach that goes beyond trauma specific care and instead aims to improve practice and policy for the entire population through organizational shifts. Implementing trauma-informed care in prison is uniquely challenging given a population with histories of trauma, the potential for re-traumatization in the system, and common under-resourcing, which may cause staff burnout. Despite this, prisons can be more trauma-informed. The next 2 slides, I have some practical do's and don'ts of that we can all practice no matter what setting we're in. And it's around like self-agency and giving space and not saying things like what doesn't kill you makes you stronger. You should be over that by now. So anyone can have access to these slides. Just reach out to Katie in the interest of time and allowing some Q&A for the last 15 minutes. I will leave it at that. I'll ask you to reflect today. Is it possible to have trauma-informed prisons, or is this an oxymoron? And yeah, I want to thank you all for letting me share space with you all today. And thank you to SUNAR.
Thanks so much, Jill. That was an amazing presentation, like very all-encompassing, very humanistic, very based on psychology, and thanks for showing your vulnerability. Like you and all the presenters, it takes a lot to do this and to share openly everything that you have for wounds and help other people. So thank you very much. The next part, we're going to be doing Q&A, which Colton is going to be hosting, but I encourage anyone who hasn't already sent in their message in the Q&A box to ask some questions. It's a great opportunity to be with a lot of people who understand advocacy at a root level. So please feel free to type in those questions in the Q&A. I hand it over to Colton.
Thanks so much, Steve. And of course, thank you, Jill, Holly, Gary, and Pete for all of your experience and your perspectives and information regarding harm reduction in carceral settings. So like Steve was saying, we're going to do a Q&A. Excuse me. And I do apologize to the audience. We weren't able to get the chat function working, but I will let you know that the Q&A function is still working. If there's any burning questions that anyone has, you can still send those in the chat, and I'll just add them to at the last of the list. All right, for the panelists, none of these questions are to any person in particular, so we can do it popcorn style, or you can simply raise your hand and we can address people as they raise their hand in order. So, excuse me, the first one is, given that harm and injustice are inherent features of carceral systems, how is it possible to do harm reduction and social justice work in a meaningful and authentic manner within such contexts?
Can you repeat the question?
Yeah, for sure. Excuse me. Holly, Jill, Gary, and Steve, or not Steve, sorry, Pete, if you wanted to turn on your cams so we can have the Q&A, that would be great. So the first question is, given that harm and injustice are inherent features of carceral systems, how is it possible to do harm reduction and social justice work in a meaningful and authentic manner within such contexts? So there's a bit of a statement there and then followed up with a question.
I think I might have answered that already in my presentation. If some, like from my own experience and what I believe is, educate, retraining of prison staff, a complete like shift in the way they're educated. And then also like knowledge is power. The first time I sat in a trauma therapist chair and they said, you're not a drug addict, Jill, you are a traumatized person. You are just like trying to cope and get through life. Like you need to lose that label. And that was just like freedom for me, understanding that.
I can certainly, oh,
yeah,
sorry,
I'm
Jill.
done.
I can certainly add to that from like a like, I'm not sure what the system's like in Newfoundland and if there is like a medical service and a correctional service, but I worked in like the medical center of corrections. And the big thing from my experience is like, I kind of, when I started the job, you know, I'm an advocate. I want it just, I was like fighting the big fight. You know, I remember vividly somebody really high up in the correctional side of the house saying to me, you know, we found a needle in so-and-so's cell. I think they're on methadone. What are you going to do about it? And I said, well, I'm going to talk to the physician and get their dose increased because clearly they're not on a stable dose. And he nearly fell over. That was at the very beginning of my time there. But as you said, Jill, through education and advocacy and compassion and just having that consistent approach, I did rub off on some of the correctional side of the house. And, you know, I remember somebody saying to me, you know, like, I know, like, I think I can speak harm reduction now because of you, Holly. Like when I was walking, I said, well, then I did my job. Like, I feel like I've accomplished what I came here to do. If I have like a person way high up in the correctional side of the house, you know, believing in harm reduction. And now I manage detox, concurrent rehabilitation program and an early recovery program. And I just started this position and we actually, I'm like collaborating with corrections. So we had somebody who's incarcerated with a bracelet come to rehab that normally would have not been able to be TA'd, but now we're developing a partnership and where I built those trusting relationships and focused on the compassion, the teaching and the advocacy. I have those trusting relationships with the correctional folks. So now we're able to collaborate and do these new great initiatives. So I think I agree with Jill. It's just educate, educate, educate.
Thank you, Jill and Holly. And yeah, I think that the way the question is formatted is that it is lending to the perspectives that people usually have in carceral systems, is that it is all harm and injustice. And we should be looking at that and questioning it. And of course, moving forward in a way that we're not just harming people, that we are helping and supporting them so that they can move forward in their lives. Gary and Pete, if there's not anything that you wanted to chime in on, or if there is, let me know.
Just real quickly, I just want to, for me being involved with this for so long, one of the things that I realized is that, you know, we had to be careful about going into it because it's such a massive system. And it's been ingrained for so many decades that, you know, it doesn't change overnight. So we had to be careful. Like for me, when I go in advocating or talking about something, that I try to break it down as much as I can and change. I work on changing like one thing at a time. So it ends up being a big picture. So we had to go with the steps of it instead of like going after the head of the dragon right away, because it's not how that's going to work. So we had to kind of like make those steps, right, and pick away at it, and eventually it works, right? So let's keep up the good fight, man. Keep talking the talk, keep meeting with the people, keep talking about the stuff that we know that works. And you know, they do change, right? They do. It's a slow moving process, but it happens.
Thank you, Pete. Gary, is there anything you wanted to add? No? Okay, thank you. I will pose the second question into the chat, but I will also ask it verbally. The second question is, do you think it will be possible for people who use drugs, if apprehended, to receive the proper harm reduction or medications? And in their example, they say safer supply and IOT, which to anyone who doesn't know, it is the intravenous opiate agonist therapy, as soon as taken into custody. Do you think it's possible they will be given the proper medications upon being released that will hold them over until seeing a prescriber? And just a moment, I'll put the question in the chat for clarity. All right, there it is. So the question to me that I think is just basically asking, the moment somebody is taken into custody, do you think that it's possible for them to start receiving harm reduction supports?
Yeah, absolutely.
No.
It's possible, but it's not happening.
Possible,
Yes.
yeah.
Right.
I was gonna say, yeah, it's possible. Yeah, it's not happening.
Okay. Did anyone want to elaborate on that, or?
I know when I worked in the provincial system, luckily, eventually we did get a physician who was quite harm reduction focused. I know in the acute care setting, there's IO protocols being implemented. I know we had an IOut client at detox, and we're not capable of administering anything IV right now, just based on our resources that we have. But we were able to meet the need with like a methadone dose adjustment. So like, I'm kind of with Gary, like I would be shocked, elated. I think it is possible I'd be elated, but I would be shocked to see IOut happen. I would. That being said, really, I think safe supply, safe injection area, sterile supplies, I think all of that should be accessible in the correctional setting. And I bet you a lot of behavioral, I bet you there'd be less people incarcerated, and perhaps if our programs met the needs of the population that we're talking about, and ultimately there'd be less behavioral issues in the carceral setting if people had their needs met. That's my opinion on that.
I'll say that, sorry.
Go ahead, Gary. I'll get to Pete after he has his hand raised.
Okay, sorry. I'll just be quick. I know when you go to the lockup here in St. John's, they you don't, if you're on methadone, which is good, they'll take you and get your methadone or Suboxone, which is awesome. But if you're not, you are doomed to sit in a cell and go through that withdrawal, which is horrible, 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 because you just got locked up for being a thief or whatever, and now you got cops coming to give you charges every 15 minutes and you're going through withdrawal. So yeah, some kind of IO program, or a doctor, a methadone doctor or Suboxone doctor in the setting of when in the lockup, when as soon as you get locked up and go in there, they ask you if you're on methadone. If you're not, would you like to be put on methadone? I think that would help people in this setting and when they get out. Yeah.
You know, the barrier to that from a clinician perspective is I need to, and this is why it was so hard, because in order for me to set somebody up on Suboxone and for the doctor to prescribe it, I had to find a community person to continue that prescription once you're no longer incarcerated. And that is hard because there's only so many prescribers in the community. We can't, like, the physician wouldn't give it unless he knew I had a plan for release, because you can't just stop taking it when you leave corrections. So that's another thing to think about.
And the fact that there is no plan for release is ludicrous. You know, like, everyone's getting out someday. Most, well, 99% are getting out someday, and there needs to be, there's not enough, definitely not enough.
Thank you, Gary and Holly. Pete, you have your hand up. Is there something that you wanted to add?
Yeah, so working in the field and, you know, in Direction 180 for several years, and then of course being involved with being on methadone and getting out and having you know, different perspectives on that. It's the massive part of all of this is communication, and the problem is that a lot of the time that the system is very siloed. And then, of course, it depends if it's provincial or federal. There's so many different factors at play, because provincial obviously has a lot less funding than the federal institutions. So, you know, the people that do work there, they're very overwhelmed with the things that they have to take care of from the day-to-day basis for them to do research and for release purposes and that kind of stuff. Like, there's so many barriers. And I will just say one of the answers that that I'm out there preaching every day is peer support, right? So if you've got people inside the prisons or outside the prisons with lived experience, how quickly are they able to make those connections, right? So if you have a person that's that, and I call it the bridge or the translator, whatever you want to call it. So they're in talking on the front line, they're talking to the people that are walking in these cells and walking out of these cells. And then they're also speaking to the professionals and creating this creating these doors to be opened, because the trust is there immediately. If it's a person with lived experience, you know, if I walked into a holding cell and said, hey, what's up? You know who I am? This is who I am, blah, blah, blah. Next thing you know, boom, they're opening up, telling me what their issues is, what their problems is. And then I can turn around and translate that, instead of it being stigmatized and a person having to speak on their own behalf with like you were saying, Gary, you know what I mean? Going through heavy withdrawal, being bombarded with charges, all that kind of stuff. They're not thinking properly in those situations, right? So anyway, I'll leave it at that. Thanks.
That is a really great point, though, Pete. Thank you. All right, I'll move on to the next question. We do have two more, and that's just in for the interest of time. So this question here, I will send it in chat first and then read it. It says, how ethical is it to provide access to tangible harm reduction means without the capacity to offer relevant substance use recovery?
I don't think everybody who uses substances, I don't think recovery is everybody's goal. So I think to be harm reduction focused, it can't be about recovery. It has to be about meeting the client where they're at and what their needs are at that time.
Thank you, Holly. Anyone else?
I think that recovery is the word itself has been too much emphasis placed on it. For recovery is a process, the same as harm reduction. You know, there's all different. To me, recovery is a part of harm reduction, right? That's the way that I take it, and that's the way that I look at it. I think that, you know, it's there's a whole spectrum with both of it, and it depends on where a person wants to go with that. If you are bettering your quality of life, that's recovery, but it's also harm reduction. So I think that we get caught up in the semantics of it. You know what I mean? We're getting caught up in the word and what the extreme is of that word. When you break it down to try and put it into a day-to-day and an individual basis, they both really mean a lot of the same thing. So I think that, you know, that's kind of my 2 cents on that one.
I love that, Pete. I didn't even think about it like that, you know, because you're right. If quality of life is improved, whether that means abstaining or not abstaining from substances, then yeah, that can be defined as recovery. I think that's really powerful. I'm going to take that away from today. Thank you.
Yes, thank you, Pete. And yeah, it is a great reminder for us to check ourselves on what we believe that recovery is, or what people's intentions are when they use substances, or what they want in their lives, and to, you know, base it on your own individual needs. But also everyone has their own different lives, and they look differently, of course.
There's a difference between recovery and recovered.
That's great. We should have that as a t-shirt. All right. Sorry, Gary, is there anything you want to add to this question before I move on to the last one?
I was going to say that it becomes a lifestyle. Like when Pete was saying, it becomes a lifestyle almost. You have to, you know, right now in my life, I can't go shooting coke, because if I do, I will spend all my money, then I will be stealing to get it, and I will be back in jail for it. But one of these days, maybe I'll be in a position where I won't have to worry about my kids, and I won't have to worry about my family, and I will have the money, and maybe I will. And I want that time to be a time when people don't look at me as the addict or the junkie. I hate those words, I'm sorry, but I want to be the person who uses drugs. You know, that's it. Not a bad person. I'm just someone who uses drugs and can do it without ending up that way, you know? And I'm sure, and there are people out there who do it, and, you know, and I commend them. I really do. I wish I could do it too.
Thank you so much, Gary. All right. So our last question is, sorry, let me just pull it up here. Can you please share your thoughts on how harm reduction practices could be integrated into parole or probation to prevent arbitrary breaches and repeated reincarceration?
I have some thoughts on this because I recently presented to probation officers in relation to my new program at Ridgewood and St. John, and something that's kind of on the table that I want to look at here in St. John is perhaps, I think a lot of services, especially like corrections and healthcare, like work in silos. So I'm thinking if we can kind of merge and work together. Perhaps there are some people who are on probation who perhaps are interested in rehab or a modified program or whatever. So number one, getting them referred from probation to rehab if that's what they want. Number two, perhaps a more modified approach could work, and we could go to them or provide some type of extra like counseling or some modified like rehab education. And I know that's not, I don't know if that's the answer, but it's just in my brain right now because of my current role. So I think we just need to work together and stop working in silos. I'm interested to see what Pete and Gary think.
You know, Gary made a great point there. You know, when he was talking about it, is you know, he wants to be able to use substances without the consequences of the extreme consequences, and I think that's probably for me when we talk about probation and parole, is that what we're teaching people? Right? It's still black and white. You know, the incarceration, oh, you used, well, now your risk has gone up, boom, you're gone, right? And that is not teaching anybody anything. That's not allowing a person to, you know, a person makes a choice that I am going to use substances. So all that does is give them this period without it. And then that creates a whole nother realm of issues, because then, like I said, they hit those 3 points when they're released, off day parole, expiry. So when they hit those 3 big changes in their life, then the substance abuse goes from 0 to 100. And that's when we get the overdoses and the deaths. And then of course it also re-triggers all those old behaviors in our brains that I have to go and commit crimes to obtain more substance. So there has to be, for me, when we're talking about parole and probation, is that ability to help educate a person as to quality of life. Okay, if you want to continue to use substances, how can you do that without creating massive harms in your life and others, without you going back to prison, without committing more crime, you know, breaking the law? How can you do that? So again, it's an educational process, right? And those wraparound services.
And possibly the decriminalization of personal drug use and personal possession is something that can tie on to that, because that clearly needs to happen. We have like a revolving door in provincial corrections, and it's like, you know, these are not bad people. This is substance use disorder being criminalized. So what do we do with that? So,
but
yeah.
even with that, Holly, like, I mean, like alcohol and THC is now legal. You know, so, but they're still incarcerating people because they breach, or because, you know, they breached their parole or bail or whatever it is. So, you know, to me, like I said, we have to teach people, okay, it's okay to use substances. It's not okay to break the law to obtain those substances. Right? So there's a fine line in there.
But unless we have services available in the community that meet the need, then really there isn't a choice, because in order to meet the need, you're kind of forced to commit the petty crimes because it's so criminalized, right? So that's the problem. Like, really, decriminalization, I think, is at the root of fixing these issues, personally. So it should start on the street, really, with police and their approach.
Those are some really good points, Pete and Holly. Thank you so much. I agree with both, actually. Gary, is there anything you wanted to weigh in on as an ending?
No, I'm good. Everybody said everything good. Yep. Thank you, though. I appreciate the opportunity.
Yes, thank you, Gary. And thank you, everyone. Gary's right. This has been an incredible webinar. I'm really grateful to have worked alongside some of you and heard your perspectives. Sorry, my cat just
Oh.
moved my curtain. And Steve will end it here for us.
Yeah, thanks for all the integral information, for everyone just opening up a lot of stuff from their past. I always learn, even though I've been involved with SUNAR for so long. Gary's throwing me up the heart, which is going to get me going. SUNAR is a lot of humanistic heart. It's people, it's their stories, it's real, it's life. It's people who have been through systems where other people have not. And those stories really matter for us to learn, and to learn how to live and meet and love, and how to meet people where they're at with the best services and the best guides to their own serenity. Give people agency and you'll have some of the best allies in the world. And I believe that's what SUNAR is all about, is pushing for agency, empowerment, evidence-based practices, and allies beyond the systems we are born into. So thank you, everyone. I want to thank the panelists again for all your information, all your abilities. And thank you for everyone coming with open minds and open hearts to receive this information. If you have any questions about SUNAR, please feel free to reach out. And also please feel free to fill out the survey. It's in the chat there. We really appreciate all your engagement with us. Take care. Empathy is great.